Hi, everybody. We are looking at chapter 14 related to psychological disorders, what most people tend to think of when they think of the field of psychology. So we'll look at some perspectives or models of psychological disorders, and then we'll go through the big categories: anxiety, psychosomatic, dissociative personality, mood disorders, and suicidality, schizophrenia, and then disorders of childhood and disorders of aging. And as a side note, if this topic interests you, I do also teach a Psych 8 class, which is abnormal psychology. And all we do all semester is go through this topic, just as a side note. So let's jump in, right? And when we look at psychological disorders, we're talking about patterns of behavior or psychological symptoms that impact multiple life areas, creating distress for the person experiencing these symptoms. So it is a pattern of significant distress and impairment that's impacting your life in some way. And I want to give you a little piece of information before we jump into this. It is a very common psychology student phenomenon to think that you have every single disorder that we talk about. Like as we go through them, you're gonna be like, oh my gosh, I have that, and I have that, I have that, I have all of them. And while it's possible to have a couple, and it's possible that you have one, of course, very, very unlikely that you have quite a few, or if not all of them. So just keep that in the back of your mind that we all possess some elements of every single one of these disorders. It's only when it really drastically interferes with your life, causing significant distress and impairment, that it actually qualifies as an actual disorder. So just something to keep in the back of your mind. And when we're trying to decide what is kind of normal versus abnormal, we sometimes use this guideline called the 5 Ds of abnormality. If a behavior is deviant, distressful, dangerous, dysfunctional, and has duration, then maybe it's something that is disordered, and we might want to start looking at some diagnostic criteria. So deviant means that it differs from like what you would expect. It's different from what's typical or normal. Now, normal and typical are very subjective terms, but it's different, right? It's not what you would expect. It causes you distress. It interferes with your life, makes things difficult for you. It's dangerous. Maybe it's dangerous to yourself in terms of like self-harming or suicidal behavior. It can be dangerous to other people when we talk about like antisocial personality disorder, for example, or conduct disorder, oppositional defiant disorder. It's dysfunctional. It makes it hard for you to meet the demands of your life, right? It causes you dysfunction. And then finally, I added the 5th D of duration. Every single disorder has a criteria for how long it has to last, how long you have to be showing symptoms in order to be diagnosed. So again, like keep that in mind as we go through that everybody's going to have a different definition of what's normal and abnormal. That's going to change from time to time, place to place, culture to culture. But in general, if something meets those 5 Ds, then maybe we need to investigate it a little bit more. Before we jump into the disorders, very common to talk about the different perspectives or models of these disorders. And these are ways of kind of framing or viewing them through a certain lens. So each disorder has kind of common culprits as to what might cause it, how we might approach treating it. And those culprits can be viewed through the lens of these models. So we have a couple of different perspectives, like everything else in psychology, tons of different theories and models. And some of these are going to explain different disorders a little better than others. Jeez. I think I've sneezed in like every single lecture video this that I've made this semester. Anyway, sorry about that. So the medical model is a very, very common model, medical or biological model. According to this perspective, disorders have a physical basis to them. So maybe they're caused by neurotransmitters or hormones being out of balance. Maybe they're caused by genetics. Maybe it's a brain structure abnormality. It's something medical or biological. And if we believe that to be the case, like for example, with depression, let's say we believe depression to be due to not enough serotonin, we can then give somebody a biological treatment that increases serotonin to try and treat it. So not only do these models kind of explain what cause a behavior, but they can also dictate treatment. The psychoanalytic model is Freud's model, believing that disorders come from unconscious internal conflicts, things that happened in your early childhood, things that are maybe due to aggressive or sexual urges being out of check. The cognitive model and the behavioral model, and sometimes together as the cognitive behavioral model, looks at thinking and behaving. So cognitions are going to have to do with the way that we think about the world, our expectations, the things that we tell ourselves, our internal dialogue. Behavioral model is going to look at behaviors, conditioning. What do we learn? What kind of associations and things have we been conditioned or rewarded to do? And then we can combine them together to get a very popular model, which is CBT or cognitive behavioral, which looks at all of that together. The diathesis stress model is another one. This one says that we are biologically predisposed to develop a certain disorder, right? And then we only will exhibit that disorder if we have a stressor that brings it to the surface. Now, that stressor could be a traumatic event. It could be the use of a substance. We'll talk about this a little bit when we get to schizophrenia, very common idea there. And then finally, the systems approach or the biopsychosocial approach says it's a little bit of everything, right? That it's biological, psychological, and social risk factors that are going to combine together to create a disorder. And then we're going to use a bunch of different techniques to then treat it. So again, certain models fit certain disorders better than others. And we'll talk about that a little bit as we go through. And then you'll see them again when we get to the treatment unit next. How do we diagnose disorders, right? So when we're diagnosing disorders, we use a book called the DSM, the Diagnostic and Statistical Manual of Mental Disorders. And we're currently in the fifth version of it, text revision, which came out in 2022. And it describes about 400 plus psychological disorders. The first DSM that came out way back in the 1950s only had about 60. But every disorder that the APA recognizes is found in the DSM. And so if you open this book, it has all the different categories of disorders that we're going to talk about, and then some. And for each disorder, there's a list of diagnostic criteria that you need to meet in order to be diagnosed. Now, diagnosing is kind of a mixed bag, right? Some people criticize the DSM and this whole system that we have because it forces us to label someone. And when you label someone, you often end up viewing them differently, right? Like it's a piece of information that can change the way that you view that person, maybe make judgments about them or change reality, can lead to self-fulfilling prophecies, right? So labeling can be a little bit mixed. But on the flip side of that, if we know that you have depression, now we know what to treat. Now we know what techniques we can kind of draw from to help you. So it can help us lead to effective treatments as well. And anytime you go to a mental health professional, they are going to diagnose you. Unfortunately, you have to be diagnosed for like insurance purposes, charting purposes. It can always change as we get more information, but we do diagnose or label people, which is a little bit of a mixed bag. But it's the system that we have for better or worse. And so let's talk about all these different disorders that we can then diagnose or label somebody with. Starting with anxiety disorders. And this is by far the most common category of disorders that people struggle with, right? I hope I don't offend anyone with the picture. I thought it was funny. Did I blow the candle out? I think I did. Did I? Right. We'll talk about OCD in a minute. But every single one of us experiences anxiety. Anxiety is normal. It's typical. It's common. It would be abnormal to never have anxiety. These are feelings of fear and apprehension caused by something appropriate and identifiable that go away with time. So for example, I'll share with you before the first class each semester, I have so much anxiety, right? Like I lay there up all night. I don't sleep very well. All I can do is sit there and think about like, what if the projector doesn't work? What if my pants fall off? What if I start coughing and can't stop? What if, right? And I would say that's okay. And that's not abnormal. But what if I'm doing that 2 months into the semester? I'm still not sleeping. I'm still that anxious. Then at that point, it's interfering with my life. And maybe I've hit the point of an anxiety disorder. So when people have disorders, they are extreme, unrealistic, and debilitating. And in this case, anxiety, which is the first group that we're talking about. One of the more common anxiety disorders are phobias. Like 1 in 10 people have a phobia. And again, most of us have things we're afraid of, right? Like things that we would rather not encounter, whether it's spiders for me, my partner, it's lizards, my daughter, it's praying mantises, right? Like everybody has something that they are typically afraid of. A phobia is more than that. It's an intense, paralyzing fear of something that's excessive and unreasonable. So you tend to maybe even have fears of things that aren't harmful to you in any way, or you avoid them and it interferes with your life in some way. Common fears are things like spiders, snakes, heights, germs. Germs like skyrocketed during COVID, and contamination fears. So lots and lots of different fears. One of the most common ones is social phobia, which is now called social anxiety disorder, where people don't like to perform or talk or be in front of other people. Now, phobias can be of literally anything. You can even be afraid of fear itself, right? And the key with these is that it's an intense, paralyzing fear that is beyond what is reasonable. So it's excessive and unreasonable in nature. Other anxiety disorders that are relatively common, another one is panic attacks. A lot of people struggle with panic attacks or anxiety attacks, sometimes called. But a panic attack is a short bout of panic or anxiety, really intense anxiety, that occurs very quickly and reaches a peak within minutes before it gradually passes. Typically like 10 minutes or less, but it could be that you feel the effects of that for the entire rest of the day or even multiple days. And when people have more than one panic attack, we call it a panic disorder. And so that's when you have recurrent panic attacks where you experience these intense experiences without any kind of reasonable cause or trigger. So again, this could be like a one-time thing, or it could be a recurrent issue. And what happens with panic attacks is people start to fear going out into the world. They're afraid to go out and about and carry on with their day because what if they have a panic attack out in public? And this is called agoraphobia. So it's so common with panic attacks that we actually diagnose this as with or without agoraphobia. And agoraphobia is kind of an odd one. It has like a multiple elements to it. It's a fear of crowds, public places, or being separated from a source of security. So like you don't want to be outside of your house because what if you have a panic attack out in the world? Or what if you can't escape? You don't want to be trapped in the middle of a row or in the middle of a room, right? So it's kind of got a couple of different pieces to it, very complicated phobia, but it tends to sometimes come along with panic attacks. Another very common anxiety disorder is OCD, or obsessive compulsive disorder. And with this disorder, people have these disturbing thoughts called obsessions. They're these involuntary thoughts or ideas that keep kind of popping into your head intrusively. And those obsessions push you to perform senseless rituals called compulsions, repetitive ritualistic behaviors that you feel very compelled to perform. Really common that these have something to do with like checking behavior, like did I turn off the light? Did I turn off the stove? Did I lock the front door? Or germs and contamination. Did I wash my hands? What if I touch something, right? There's a lot of very, very common obsessive compulsive kind of rituals that people engage in. And again, all of us do a little bit of this, right? Like every night before I go to bed, I check the front door to make sure I locked it. I would even say checking it twice isn't abnormal. But what if I'm laying in bed and I can't sleep because I'm so convinced I didn't really lock the door? And now I have to go check it again for like the third time, the fourth time, and I lock it and unlock it like 5 times just to make sure I really did lock it. Then you've started to transition out of kind of a typical level of anxiety into more of a disorder. Another group of disorders, psychosomatic and somatoform disorders. These ones are really fascinating, not super common, but they definitely happen. Psychosomatic means that there's some interplay between psychological factors like stress and anxiety and your health. So, for example, people can have things like illness anxiety disorder, which used to be called hypochondriasis. Really rare, there's something called conversion disorder, which used to be hysteria. But with all of these, what we see is that there's some kind of interplay between the mind and the body. And if you just look at the term psychosomatic, psyche is mind, soma is body. So it's mind-body disorders. Conversion disorder is when people convert something traumatic into like a physical symptom. So they witness something horrible and go blind. Nothing wrong with their eyes. They're not even doing it on purpose. They don't even know that they're doing it. And once you realize you're doing it, your vision starts to come back. Illness anxiety disorder is more when you are like obsessing about your health. Maybe you're constantly Googling your behaviors, going from doctor to doctor, getting second, third, fourth, fifth opinions, right? All of these have some kind of interplay between those two. And there's a strong psychological component that's interacting with that physical component. The dissociative disorders are even more rare, but I guarantee you've heard of dissociative identity disorder, which used to be called multiple personality disorder. With these disorders, some aspect of your personality becomes separated from the rest, or you have multiple identities or changes in identity, or you're dissociating or depersonalizing. There's a couple of different elements here. But what happens is that you dissociate from your personality, and oftentimes it leads to memory loss, changes of identity, or the presence of multiple identities. And that's what we see in dissociative identity disorder, when people have two or more distinct fragments of personalities that routinely take over. And depending on the relationship between those personalities, it can really dictate how hard this is to live with. If they all know about each other and they share memory, it's actually not that bad. But when they don't share memory and you switch from A to B and then B to C and C to D, and none of them have any awareness of each other, there can be quite profound memory loss, and it can be very, very disorienting. Featured in a lot of great shows and movies. Probably one of my favorites was Bates Motel. Another really good one was Identity. United States of Terror, kind of more of a comedy, but lots of shows and movies featuring dissociative identity disorder. Another group of disorders are the personality disorders. Now, we all possess a personality, hopefully just one, or we have dissociative identity disorder that we just talked about. But we talked about personality a couple of chapters ago. It's everything that makes you you, right? Your unique and enduring pattern of thoughts, feelings, and behavior. Now, a personality disorder is when people have inflexible, maladaptive ways of thinking and behaving, and they tend to start very early in life and persist. It's everything about you, your personality and your way of interacting with the world, in essence, is the disorder, which is kind of what makes these so controversial, because we're in essence saying it's everything about you that is like problematic, and it makes it really difficult to change if that is your identity. Now, there are 10 of these. We're only going to talk about like the two most dramatic ones, but they tend to fall into a group of like odd and eccentric ones, anxious and fearful ones, and then dramatic and emotional ones. And again, if you're interested in more on this, you could sign up for Abnormal Psych and you go into all of these. But we're just going to talk about two. And these are two of the most dangerous, if you will, dangerous to self and dangerous to others. So borderline personality disorder and antisocial both fall in that like dramatic emotional group. And they both are very like dramatic. They can be very challenging ones to live with, or have people in your life who have them. Borderline personality disorder, kind of interesting name, borderline of neurotic and psychotic. Neurotic means you can't control your emotions. Psychotic means you're out of touch with reality. And it was thought that it was kind of on the border between the two, which is where the name came from. But this is a disorder characterized by a lot of instability in self-image, mood, relationships. There's a lot of like love, hate, push, pull, tending to have a lot of things in common with like bipolar disorder, a lot of correlation there, and people really struggling with relationships with other people, and a lot of instability and impulsivity coming with it. Antisocial personality disorder is probably most dangerous to others. If borderline was most dangerous to self, antisocial is most dangerous to others. This is somebody who has a history of like violent and criminal behavior. In fact, in order to be diagnosed with this, you have to have shown signs of this during childhood. You have to have what's called conduct disorder or oppositional defiant disorder when you're young, and then it persists and gets worse when you're older. This is commonly known as being a psychopath or a sociopath, which kind of more refer to the causes of the disorder, but the technical name is antisocial. And we see a lot of like violent, criminal, and unethical behavior, a lot of like superficial charm, superficial charisma. The key, though, is that this individual tends to not feel any guilt or empathy toward other people. And so a lot of movies featuring this one as well, characters like Hannibal Lecter, Joffrey, and what's the other guy? Oh, I'm forgetting his name. Um, the like brutal guy. Oh, it's gonna eat at me from Game of Thrones, right? So many Alex from A Clockwork Orange. The Joker is another example. So many examples of this in film, tending to have that like superficial charm, but very ruthless and often lack of empathy and lack of guilt. The second most common group of disorders are the mood disorders. These ones affect a lot of people, things like depression and mania and bipolar disorder. This is when people have a disturbance in their mood. Now, all of us are going to have like ups and downs with our mood, but this is emotional extremes. So maybe you're really, really down for a long period of time, or you're really up and agitated for a period of time. The low end of mood we would call depression, right? If we think of mood as like two poles, we would call the low end depression. So major depressive disorder is when people are overwhelmed with sadness, they have a lack of interest in activities, they struggle with eating, and they struggle with sleeping, a lot of feelings of like guilt or worthlessness. You just don't get pleasure out of the things that you used to enjoy. On the extreme flip side of that, we can have the up end of mood, which we call mania, a very, very like up and euphoric state where people are manic, right? They're extremely like talkative, distractive, grandiose, right? They have the big ideas, oftentimes not sleeping, engaging in like reckless, impulsive behavior, behavior with a high potential for dangerous consequences. So people can have one end or the other. If they have both, we call that bipolar disorder. Used to be called manic depression, which makes sense, right? Mania and depression. But technically, there are two levels of mania and hypomania. So we changed it to call it bipolar disorder. And with this disorder, what we see is that people have alternating periods of like very low mood, followed by very high mood, and oftentimes normal mood in between, right? So it might be that you have weeks of being depressed and then normal mood and then a manic episode, right? And oftentimes this can feel like almost two different people when people switch between these different episodes, right? Very, very extreme. And one of the harder disorders and more stigmatized disorders for people to live with. Very commonly correlated with mood disorders is suicidality. A lot of people who are depressed become overwhelmed with hopelessness, feeling that things will never get better. They don't see any way out of their difficulties. And that can often lead to like self-harming behaviors or suicidal behaviors. Lots of warning signs of this. People talking about dying, having big losses in their life, really severe depression correlates very highly. Changes in personality, giving away possessions is a big one. Somebody has that guitar that they never let anybody touch, and all of a sudden, hey, if something happens to me, would you take this? Or I'm going to give this to you to look after. Fear of losing control, especially in like the elderly population, right? If maybe someone who's dealing with like a terminal illness or like a serious illness. Having low self-esteem and no hope for the future. Hopelessness is the number one correlative of suicidality. When people feel like it's never going to get better, things are just never going to improve, oftentimes suicidal behavior or self-harming behavior is the next kind of step that they go to. Some causes of mood disorders, like everything else, like most of these disorders are kind of a combination of risk factors. But we see a lot of biology with mood disorders, right? A lot of things related to like serotonin, different parts of the brain. We actually discovered a brain circuit that plays a big role in mood disorders, which is why things like TMS are so helpful, or like on the horizon for things that will be helpful in the future. Social factors can play a role, psychological factors can play a role. Obviously, when people experience something really difficult in their life, that can be a correlative experience. Cognitive distortions are also a big part, right? Thinking patterns play a big role in depression. Oftentimes when people are depressed, they engage in very like black and white thinking, very like illogical thinking patterns, and that only fuels more depression. Right? So what you often get is that people have some kind of stressful experience. They view it in a very negative way, which leads to depression, which causes some more cognitive and behavioral changes, which leads to more stress. And it's just kind of like round and round we go. So very common to try and tackle those thinking patterns, also to consider things like medication, which we'll talk more about in the next chapter. Another group of disorders, some of the most severe disorders that we'll talk about, schizophrenia. Schizophrenia is a psychotic disorder. And what that means is you've lost contact with reality. Due to the nature of the disorder, you oftentimes don't know what's real or not real. You're having bizarre, thoughts about the world. You're seeing or hearing things that aren't there. The connections between your thoughts are off, odd motor movements. There are a lot of symptoms of schizophrenia, enough so that we used to divide this up by the different types of symptoms that people could have. But now we tend to talk about it in terms of three groups. So we have positive, negative, and psychomotor symptoms. And like every other time in psychology, positive here doesn't mean good, right? It's not the good symptoms of schizophrenia, it's excesses. And these are by far the most common. People have things like hallucinations. They see things or hear things that aren't there. It could be people, it could be figures, it could be sounds. Hearing voices is by far the most common. And the other one that we often see is that people have what are called delusions. They have false beliefs about reality that have no basis in fact. Maybe they have paranoid delusions or delusions of grandeur or delusions of reference where they kind of read into everything. And you see a lot of movies featuring characters with this. The Soloist is a really great example. A Beautiful Mind is another one, right? But hallucinations and delusions are two of the most common symptoms of schizophrenia. There's also negative symptoms. These aren't as dramatic, but they're oftentimes people talk very little or move very little. They don't have a lot of volition. They don't express a lot of emotion. It can be kind of like a very like blunted affect. And then psychomotor symptoms can be things like odd movements or tics, kind of constantly moving, playing with your hair in certain ways. You can get stuck in a catatonic state where you don't move or respond to the world around you, right? Some combination of all those different symptoms leads to a diagnosis of schizophrenia. And with this one, we look a lot at neurotransmitters. This is thought to be very biological in nature. Dopamine plays a huge role in the development of schizophrenia. And so does that diathesis stress perspective that we mentioned. It's thought that people are born with a predisposition to get schizophrenia, and then maybe some kind of environmental trigger pushes them. That could be the use of a substance. If you have ever heard of like drug-induced schizophrenia, it could be some kind of trauma, going to combat. Anything that is experienced as extreme stress could trigger that inborn predisposition and launch somebody into schizophrenia. There's also some disorders of childhood, followed by disorders of aging. Disorders of childhood are disorders that tend to affect kids, right? And these are things that we see a lot of, things like ADHD and autistic spectrum disorder. ADHD is when people have patterns of inattention, impulsiveness, and hyperactivity. We used to have ADD, but it was absorbed into the ADHD umbrella, so that's no longer a thing, just as a side note. Autistic spectrum disorder, or ASD, is a spectrum disorder, right? So rather than just saying autism, we say that someone has autistic spectrum disorder. They're somewhere on the spectrum of this developmental disorder. It's got a lot of extreme unresponsiveness to others, poor communication patterns, highly repetitive, rigid behavior. And again, this tends to exist very much on a spectrum where some people, this is so severe and profound that they struggle to function. Others might be very high level functioning or even have areas of like giftedness that could be part of it. But we see generally a lot of like lack of responsiveness, kind of closed off to the world around you, a lot of language and communication struggles, repetitive, rigid behavior, a lot of motor movement kind of things. We also see there tends to be like a fixation or obsession with certain things. As a side note, with this one, we used to have a disorder called Asperger's that was its own distinct disorder, and now it's been absorbed as part of the spectrum. People who tend to have kind of a high level of intelligence, but really, really struggle socially. So again, a lot of different things fall under this umbrella, but in general, we would call them being on the spectrum or autistic spectrum disorder. Finally, in terms of the other end of life, disorders of aging, and we talked about a couple of these before, but one of the things that's very common in the later years, so like 65 and older, are the neurocognitive disorders. Now, these used to be called dementias, and most people kind of commonly refer to them that way. But neurocognitive disorders are when people have severe problems in memory and cognitive functioning. By far, the most common of these is Alzheimer's disease, named after Alois Alzheimer's, was the one who kind of coined this back in the early 1900s. But this is by far the most common type of dementia. Very common after the age of 65. Like 1 in 10 people over the age of 65 get this disorder. It's not thought to be genetic, it's just a product of aging, unless it happens earlier, in which case it might have a genetic component. This does tend to be fatal, right? It lasts about 8 to 10, excuse me, 2 sneezes, right? 8 to 10 years on average between onset and death. And it's the result of two things called neurofibrillary tangles and senile plaques. Everybody possesses these tangles and plaques, but people who have Alzheimer's have an exorbitant amount of them. They're these twisted protein fibers that form within the brain as we age, and then they start to interfere with the way our neurons communicate with each other. And it slowly and progressively moves from like one part of the brain to the other, and it gets worse and worse. And then these plaques build up in the spaces between our brain cells, and it just gets more and more damaging the older that we get. Literally at the end of this is your body shuts down and forgets how to function. Something very small, like a cold, could be enough to take you out. We have a lot of treatments for this, but right now they mainly focus on slowing it down and prevention. So this is something that we don't have a cure for, but we are working on it very aggressively because it affects so many people. One of the best things that you can do is prevention, right? Get good sleep, have a good diet, keep your mind active, have lots of social involvement, do all the little things that you know to do to take care of your health. And you can drastically postpone this quite a bit. But Alzheimer's, Lewy body dementia, Parkinson's, Huntington's, there's quite a few disorders of aging, with Alzheimer's by far being the most common. Okay. So those aren't all the disorders, but those are most of the big ones, kind of looking at most of the big categories. As always, same reminders, don't forget to read the chapter in the ebook so that you get all of the details and information. Don't forget to go through the lecture, click on all the links, watch all the videos. The combination of this plus those two other things will really help you to understand all the content. And I will see you for our next chapter, which will be chapter 15, looking at how do we treat all these disorders that we just talked about.